So this is Intrapartum Nursing Care, Part 2. This covers class 7 and 8 in the course, and will be tested on exam 2. This is covered in chapter 15 of your text, and we're going to discuss the nursing care that we provide to a laboring patient and a patient immediately at birth. So, admission to the birthing facility, that begins with the decision to go to the hospital or not. And it's based upon a bunch of different factors. Number and duration of any previous labors is a big one. So if it's a first-time baby, we usually have a little bit more time. If it's a second baby, a multip, or a grand multip, we have a little bit less time. So we will let people stay home in labor as long as their water hasn't broken. If their water breaks, we do like to bring them in and have them confirm that their water has actually broke. And there's a couple ways that we can do that, and we will talk about that. The distance from the hospital, so if they can get, if they live 10 minutes away and they can get there easily, then we will have them wait, or allow them to wait if that's what they desire. And if they live an hour away, we might not be as keen on doing that. Available transportation, so do they have the means to get there when they need to get there? And then who do they have to watch their children? Other children, we are known for coloring with siblings at the desk if we can't get someone in to watch the older sibling while mom has her baby. And then risk status. So if they're a higher risk pregnancy, we're more likely to have them come in. If they're a lower risk pregnancy, then they can stay home and labor at home a little bit longer. So what is our responsibility during the admission process? Our first thing is we try and establish a good relationship with them. And it depends on what stage of labor they are in, how effectively we can do that. If they're in active labor or in transition, they are not themselves. They are not really interested in small talk, as opposed to if they come in and they're in latent labor, that first stage early, they're contracting, but they're able to just talk to you in between. Then you can kind of get to know them a little bit and, establish some confidence. We want to promote continuity of care, so we do try and assign the same nurse to the same patients over again, especially if they've developed that relationship. It says here to use touch for comfort. You really have to be careful with that one. Some moms in labor, are fine with you touching them. Other ones do not want that interaction at all. So you have to really, gauge that based on the individual. And then respect any cultural values that may be present. Some cultures only allow female providers. They will not allow a male provider, and we have to the best of our ability, accommodate that. And then determine family expectations. So again, in that latent phase, sometimes if they're inactive, they'll come in and hand you a piece of paper with what they want for their labor experience. If they're in the latent phase, you can have that conversation with them just to kind of get the lay of the land of how they want their labor to go, how much intervention do they want, what are their expectations for their experience, and then do we need to help them, kind of come to terms with, we can make your experience what you would like to the best of our ability, but obviously our goal is a healthy mom and a healthy baby at the end of the day. So during this admission process, we do a quick focused assessment just to see, get a window into how is this patient doing obstetrically. So we want to throw them on the monitor. We'll get a fetal heart rate. We want to make sure that heart rate is between 110, 160. Take note of the presence of accelerations, which indicates our good oxygenation and neurological intact baby, and then absence of decelerations. We want to take mom's vital signs. Again, very important to take those vital signs in between contractions because contracting alters the accuracy of those vital signs, especially blood pressure and heart rate. Identify signs of hypertension and infection if appropriate, and then be aware of these warnings that they may deliver quickly. So any kind of urgency to push, any bearing down or grunting noises, that means that you probably should get that mama in a bed and let her have her baby, because it's coming quicker than we can move to admit her. Usually in that case, we deliver the baby first and then we admit them. And it's kind of almost nice when that happens because, you skip all the other stuff and then you can kind of take your time and admit the patient while they breastfeed, while they hold their baby, and it kind of shortens up the whole process. We want to do, a basic assessment from the time that they come in, getting anything that you would in a regular assessment after that initial focused assessment on their obstetrical status. So basic information, a head to toe physical exam, assessment of the fetus, which we get from our fetal monitoring, and then what's their labor status. So are they contracting? How often are they contracting? How strong are those contractions? So just measuring all the aspects of their contraction pattern, and then establishing if they are ruptured or not. So sometimes women come in and they say, oh, I've had a gush of fluid, which means that they need to come in and be evaluated. Sometimes it's what we call grossly ruptured, which means that you have visible fluid, they cough, and fluid is expressed, and you can say definitely, okay, definitely this person's water has broken. Other times it's like a little tiny trickle, or a small gush and then not much after that. One of the good sign, not good sign, one of the better indicators that their water has actually broken is if you ask them if they're wearing a pad or not, because if they can walk around with ruptured membranes without a pad, then they're probably not ruptured. If they come in and you can't see fluid, they cough and no fluid is expressed, you might have to, the next step would be to do a speculum exam with, and take a swab of the fluid that's present in the vagina. So you do a speculum. I do not do the speculum. The physician will do it. Put the speculum in, take a swab of fluid, put it on a slide, and they look at that dried amniotic fluid underneath a microscope. So if amniotic fluid is present, when it dries, it looks like a fern. So we call that the ferning test. And if they have positive ferning, that means that there is amniotic fluid present on that slide. If there is no ferning, then there's no amniotic fluid, which means that their membranes have not ruptured. And we, essentially then we are looking if their contraction pattern is adequate in order to consider them in labor. Are they making cervical change that would declare them in labor? We cannot do, this is really important, you need to star this, you cannot do a vag exam, a cervical assessment, if they we're ruling out rupture of membranes. So until we know whether or not their water has actually broken, you can't do a cervical exam, because the gel that you would use alters the consistency of the amniotic fluid and can throw off the results of that ferning test. An additional test for establishing if they've ruptured their membranes or not is called we use litmus paper, and you put a little bit of the fluid collected from the vagina on the paper, and it will turn the paper a different color if it depends on what brand you have, depending on the color that it changes, but a different color, and it would indicate the pH or acidity is different in amniotic fluid. So if it changed the color, then you could declare them ruptured by that way as well. So they're either visibly ruptured, we've done ferning and we've determined them to be ruptured, or not, and we could also use litmus paper, and we are not doing a cervical exam until we determine their rupture of membranes if they come in and that's what they're complaining of. Because sometimes they come in and say, oh, I had a gush of fluid, they're not wearing a pad, and then it's probably just urine from that baby pouncing on their bladder. So that happens sometimes too. But we never make them feel like they shouldn't have come in, because you do want to make sure that they come in when they need to. It's better to rule them out than to have them walking around with ruptured membranes for an extended period of time and not know it. Once we collect all of this information about their contraction pattern, we're going to notify the provider, give them a little report on the strip that we've gotten. Are they here because they're ruling out their rupture membranes, and do they need to come and do the speculum exam? Are they just there for rule out labor? And in the event that they're there for rule out labor, they don't think their water has broken, but they're there just to see if they think their cervix is changing. A nurse who has, we have something called a medical screening provider, which is a nurse who has taken fetal monitoring classes and has 2 years of labor and delivery experience. Those nurses on the unit can check the patient, wait 2 hours, and recheck the patient and determine whether or not someone is in labor, and then admit them. So that's a pretty, significant amount of responsibility, especially because that means you could potentially not have the physician see the patient prior, in the admission process. So we're determining many times, the nurses that have that 2 years of experience in fetal monitoring course under their belt, whether or not this person is actually in labor. And I know that seems kind of silly because, either they are or they aren't, but sometimes it's a little harder to determine than you might think. So sometimes that was something that kind of scared me when I was first an OB nurse, was I never wanted to admit somebody, give them an IV, potentially give them an epidural without having seen a physician. And that has happened, and that does happen, and it's scary. But the more experience you have, the more comfortable you become with it. And then the other thing that we want to do is obtain consent forms. So there's a few consents that they need to complete when they come in. They complete a blood consent. So we have everybody consent to blood products before they are really far along in their labor. That's if they come in early on in their labor. If they come in active labor, they sign it usually just because they want you out of their face. But this allows us to give them blood products in the event of an emergency. And we found that consenting them before they even really got too far in their labor was better than, consenting them when we actually potentially needed it. So we just have it on hand. We also do a consent for the management of labor and delivery by whichever provider is on that day. The provider needs to go in and discuss with them, informed consent. They need to provide all the details and all of the risks and benefits of different paths that they may take for their labor, and then the patient can sign. You need to make sure that if you're going to be a witness on either of these forms, that you are present for the discussion. So that's something that sometimes gets a little bit loose at the more, the longer you've been a nurse, and some physicians, really you just develop like a very trusting relationship, but legally you need to be present in order to witness on a consent. There's a couple other consents we'll talk about a little bit further on down the road in terms of induction and augmentation, but for our initial admission, the blood consent and the management of labor and delivery are the two big ones. Lab tests. So whenever anybody comes in admitted into labor, they get a CBC. We like to see what their H&H is. before they deliver, so that we can compare it to a post-delivery CBC and see what their H&H is after. It's a good indication of blood loss. We usually collect a urine as well, so a CBC, urine, and we do a clot for hold. So we take extra blood and then we run a type and screen on it, in case we need blood products for that patient. So we typically draw our own labs on OB. If we miss when we put in the IV, I will call the lab to come and draw them, just because they do it all the time, and that's just kind of our standard. I usually try and draw their labs when I put their IV in, but if I miss, then I call the lab. Intravenous access. So like I said, most women will get, depending on the stage of labor that they're in, they will get either a well just for access in the event that we need it. If they are further on in their labor, they might get fluids through that well. They might get running fluids the closer they are to delivery, or depending on whether or not that they want an epidural. Sorry, I stuttered. Depending on whether or not they want an epidural, they will need a bolus of fluid before that epidural. So we do need IV access for that. So when we start the fluids depends on what kind of intervention they need. So commonly people will ask me whether or not they can refuse an IV, and they can, but I usually strongly encourage them at least to get the well, because the time that you need IV access is not the time to try and get it. So I always say, it's just there as a safety net in case we need it. And then ongoing assessments after that initial, start out is if we're going to, obviously we've either ruled them in or out of labor, and we've determined whether or not they've ruptured their membranes. So after that initial admission process, we move on to what we have to assess throughout labor. So maternal assessments throughout labor include monitoring how is their labor progressing. Do we need to, assess their cervix? At what points do we need to assess their cervix to see if they're making progress? And we talked a little bit about this, but, you don't really want to do vag exams just to check, because the truth is, if mom's contracting, she made initial change, she's progressively getting more uncomfortable, and the baby looks good on the monitor, then the truth is you don't really have to check them until they feel an urge to push. We would check them if they didn't act like their pain level was increasing, or their contractions weren't getting closer together, or if the baby was suffering some sort of compromise based on the fetal heart rate strip. Then we would check them and see what's going on. Contractions, we're monitoring those contractions, making sure, again, are they closer together? Is there sufficient resting tone, or sufficient amount of time for an interval, which is 60 seconds, because we want them strong enough to make change, but we don't want them so strong that that baby doesn't get an adequate rest, and mom doesn't get an adequate rest as well. Intake and output, so we get them up and let them void every hour. We want to keep that bladder empty so that the baby's head can come down, and we usually start that intake and output once their IV is placed. We're continuously monitoring their response to the labor. How are they coping? Usually this fluctuates from individual to individual, and then sometimes up and down within that same individual. So, sometimes they cope with it better than others, and we can help that support person and teach that support person to know what to do to be reassuring and supportive to that mom who's in labor. Sometimes they just kind of stand there because they're afraid. So, we can say, okay, here's the pitcher of water, go get water. Here's the washcloth, don't get in the ice water and put it on her head. Like, kind of conduct them in the right way, and then they pick up from there. Most of the time it's not that they don't want to help, it's that they just aren't really sure what to do and how to help, and they really don't want to be in the way. They say that all the time. Oh, I don't want to be in the way. Well, we'll put you where we need to put you, and then you can do your job. and I can do my job. And then fetal assessments, so we're assessing that fetal heart rate, making sure that we're looking at that continuously. As long as they are on the monitor, you're responsible for what happens to that baby. So intermittent monitoring in that latent phase, in the first stage of labor, so every hour you're probably putting them on. As they become more active, they probably are going to be on at least every hour, and if they wind up getting an epidural, they have to be on continuously. And then once transition hits, we usually are frequently putting them on. I would say they need to be on continuously at that point. Other people would disagree with that. I want you to know that some people have a very hands-off approach, and that's just based on, the protocol says that they don't need to be on. They can be intermittently monitored until delivery. However, physicians and nurses really like to know what's going on the closer that we get to delivery, so we know what kind of baby that we're getting once it's delivered. Is it, has it had compromise previous, or is it, in good shape with good variability, good accels? So one way that we can modify or augment, okay, we talk about augmentation of labor, which means that they went into labor, but then they kind of slowed down. Okay, so one way that we augment labor or change it, increase the rate at which it's going, is that we can rupture their membranes. And when we call it artificial rupture membranes, you might also hear it referred to as AROM. And this picture is a picture of an amni hook. It looks like a crochet hook, and it does exactly what it looks like it does. You go up into the cervix and you kind of snag the amniotic sac with that sharp point, and then it breaks the water, and that breaking of the water releases prostaglandins that will then help that labor continue or increase its rate. So that is one way that we can augment labor. Some of the important things to know about breaking their water are on the next slide. So why would we break their water? Again, we can use it to augment their labor or change it. We can also use it to induce labor. So sometimes multips who have had a baby before, their body really remembers what to do once those prostaglandins are released. So sometimes a multip, all you need to do is break their water and it kicks them into labor. Another reason why we might do it is to allow for internal fetal monitoring. There are risks associated with this, obviously. So anytime you're doing a procedure internally, introducing infection or bacteria from the outside in, you have a risk for infection. And then once they're ruptured, they are, at a minimal risk, as long as you're minimizing the number of SVEs or vag exams that you're doing. Another risk factor for this is abruptio placenta, where you can actually nick the edge of the placenta and cause a bleed, and it can pull away from the wall of the uterus. Very, very rare, and usually a skilled physician can avoid this pretty much 100% of the time. Prolapse cord. So a prolapse cord is when you break their water, and it's kind of like a waterfall, okay? So there's some force behind, and there's pressure behind that fluid. So sometimes that fluid can act kind of like a waterfall and push the umbilical cord out of the cervix. That is a medical emergency that needs to be taken care of quickly, usually resulting in a trip to the OR most of the time. There are times that you can go in and move the cord, reposition mom, and it can sometimes move the cord, but you really can't usually correct this once it happens. So when you break their water, you must be on the lookout for did that cord poke through. And one of the first indications, if it's not felt by the provider when they do it, is that the fetal heart rate will drop quickly, just like a variable decel. And it likely will not come back up because there's no relief from that cord being pushed through the cervix. So prior to breaking their water, the nursing considerations that we need to take into account, we need baseline information. So they need to be on the monitor for 20 to 30 minutes prior to the procedure. We assist with the procedure, so we place pads underneath, and I always think it's funny because like they'll come in and be like, okay, we're gonna break your water, and then they don't give me enough time to put like towels in to catch the massive flood that's coming, and it makes a mess all over the bed, and then you have to change the whole bed. So I always like learn to put a bunch of towels and those little blue chucks on the windowsill so that I can quickly scoop those underneath if, you know, whenever the physician is trying to do something like that, because it just makes a mess. Equipment, so you want to make sure you have sterile gloves to hand off, and you want to make sure that you have the amni hook ready. There's another method they call that they can use as well, and it's called a finger cot, and it's just like, it looks like it honestly looks like a condom, and you put it over your finger, and it's got like a little bit of a hook at the end of it, so they just kind of use their finger to snag the bag as opposed to the hook at the end of the amni hook. So that's just another method of breaking their water as well. And again, we want to identify any complications, so we would be looking for a cord, visible cord. Sometimes it is protruding from the vagina. That's how, you know, blatantly obvious that it is. Other times you can only see it on the monitor, so an abrupt drop in the heart rate. And then during this procedure, we promote comfort, so we put them in, you know, a supine position for the time being, just for the checking and the breaking of the water, and then we can, you know, reposition them to right, left, lateral, hands and knees. We let them stay, we make them stay in bed, though, for a half an hour after we break their water, because it allows that head to come down. That cushion that was there from the amniotic fluid is gone now, so we allow the head to come down and apply itself. That will help prevent a prolapse cord from happening as well. So leaving them in bed after the completion of the procedure is important for 30 minutes. So 30 minutes on the monitor before, and 30 minutes in bed and on the monitor afterwards to make sure there's no issues. So labor support, so that's the biggest part of our job. We're monitoring how they are coping, how they are doing with their labor as it progresses. So nurses are, you know, we're constantly reassuring them that they're doing well, constantly teaching them, helping them to know how to move, what positions to try, what different pieces of equipment that we can use, just continuously teaching them throughout the process. We're providing their comfort, so lighting's a huge one, low lighting, softer lighting as opposed to bright fluorescence, temperature, adjusting the temperature to meet their needs, cleanliness, that's huge. I don't think people feel good when they are grubby and dirty, and you know, and sometimes labor can be a little grubby and dirty, so keeping them clean is a big pet peeve. Oral care, giving them the toothbrush every, you know, 8 hours to let them clean their mouth out. They're panting a lot, so they get dry. Their mouths get very, very dry. So a lot of times we tell them to bring in chapstick. We use ice chips to keep their mouth, you know, to moisten their mouth. Bladder, again, emptying every hour. They're going to be very uncomfortable if they have a full bladder and they're contracting. So making sure that they're voiding. Breathing, so there's a whole class focusing on breathing to help with like pain control. Lamaze was back in the day. We don't really have Lamaze around here anymore. And there are different breathing techniques, and if you look in your book, there's a ton of them. Usually we teach the techniques in childbirth class, and then by the time they get there, they're like, I don't know what to do. So just slow, paced breathing. We also, one of the big things that I use is a cleansing breath before and after. So nice deep breath as the contraction is starting, and then a slow paced breath throughout the contraction, and then a deep breath and a long expiration after the contraction. So those two cleansing breaths at the beginning and the end of the contraction kind of help you to be like, okay, that was one contraction and I don't have to do that one again. And then positioning wise, we're going to talk about different positions in the upcoming slides that help move baby, help mom be more comfortable, but we encourage position changes every half an hour just to keep things moving. And then care for the birth partner. So making sure that they know that just because mom can't have solid food doesn't mean that they shouldn't stay, hydrated. They should eat. They should go to the bathroom. They need to take care of themselves so that they can help us take care of mom. So there's a variety, obviously, here of different positions for labor. The side lying position is great in latent labor, just allows them to have some rest. You can't really tell here, but this nurse is applying counter pressure to mom's back. So if you take a hand and you put it right at the top of mom's butt crack and push on her sacrum, that can help a lot with back pain with labor, and is more common with a baby who is in an occiput posterior position, as we talked about. So that counter pressure on their bottom is a great way to relieve that lower back pain. And side lying is good in early labor before they get too uncomfortable. You want them to rest as much as possible early on. This position is, I've seen a couple of women deliver in this position, kind of leaning forward, up on their hands, up on their knees. Any position that is a squatting position, so like this one, this woman is on the birthing ball. I don't really know what that lady's doing to her head, but this person is on the birthing ball, and then this person is squatting with a bar that she's likely pushing. But any type of position that's a squatting position, it is better because it opens up the pelvis and allows the head to come down, but they're often more intense. Contractions are felt more intensely in those positions because it is direct pressure on the cervix. So although it might get the job done quicker, you might need to take frequent breaks from those types of positions. This one I don't see very often. Nobody's very comfortable, nobody is comfortable enough to be sitting in a rocking chair. But sometimes in latent labor that we'll put them in a rocking chair, and the rocking actually helps move their pelvis a little bit. And when mom moves, baby moves. So by moving mom frequently, you're providing that baby an opportunity to perform those cardinal movements down into the pelvis. And kind of helping labor to progress quicker. Okay, so hands and knees, this is a great one for back labor as well, because gravity pulls the baby's head away from the sacrum. And then we see a lot of people up and walking. We think that's a great thing to do. It helps kind of take your mind off of things. And then as well, every hallway has a bar here, a handle, so they can kind of stop, work through their contraction, and then walk some more. Movement usually keeps their mind busy. So these are some pushing positions in addition to that squatting bar that you saw on the previous slide. This is a semi-sitting or a lithotomy position. She is this is the most common position that providers deliver in, or women deliver their babies in, and providers prefer. It's just easier for the provider. However, it's not the most, it's not the best way to push your baby out. I know that's going to sound controversial, but it kind of is. We rarely see women deliver in squatting positions, which is actually the preferred position to deliver your baby, and it's usually a matter of convenience. This position, side lying, we flip them back and forth a lot, especially if you have an OP baby. Side lying helps that baby to turn, and there are things that you can do to help to get that baby to turn. Okay, so side lying is one of them, so they can pull that top knee up and kind of use that top knee as some leverage to push more effectively. Another method for helping OP babies turn to OA is if you put a ice pack on the front of mom's belly, like down by her pubic bone, and then you put a hot pack on her sacrum, on her back. Babies are it's an old wives' tale, but babies tend to turn towards heat. So if we want that baby to turn, sometimes we'll put a hot pack on the mom's back, an ice pack on the front, so that baby will turn their head and face towards the warm part of mom, towards her back. The other thing that we use in labor, which is not pictured in any of these pictures, but is a peanut ball. They're relatively new. They look like a styrofoam peanut, but on a gigantic scale. And there's like a little sunken area in the middle, and we stick that in between mom's legs, and I call it the magic peanut ball, because babe, once you open up mom's hips like that, by widening her legs apart, that will we have babies that are so stubborn to turn, and then you put that peanut ball in, and within a half an hour they're like, I have an urge to push, and I'm ready to go. And I mean it, like 30 minutes. I've had multips who are 9 centimeters for hours, and then we get the peanut ball out, and the baby turns, and we deliver successfully vaginally. So pretty exciting. The peanut ball's a nice thing to see. Okay, so in relationship to pain, there's definitely a lot of options for pain management these days during childbirth. This content is covered, the majority of it is covered in chapter 13. There's a couple of things that I do cover that are not in your book, just so you're aware, so pay attention to those slides. The biggest part of pain management in labor is that everybody experiences pain differently. I have seen people at 10 centimeters with an epidural clutching the side rail, in excruciating pain, and I've seen people who are 10 centimeters dilated and French braiding their hair. So I really don't think that I think this was a front row seat to how people really handle, cope, perceive pain differently in L&D. So the two components that we talk about are the physiologic and the psychological. So there's physiologic pain that they feel, and then there's the psychological component of it, in terms of how are they able to cope with that pain. So pain is subjective and personal, and we have to remember that the women who are coming through here, this might be like their first real experience with a pain level this high. Okay, so a lot of times how they cope with their pain depends on their experience with pain in the past. So we have to keep that in mind. If they've only ever, if they've had minimal experience with pain in the past, then they're going to have probably a little bit more trouble. Birth pain differs from other types of pain in that it's part of a normal process. It's expected. If you didn't get the memo that labor hurts, I don't know where you've been living, but probably under a rock. There's preparation for there's time to prepare for labor. So if you want, and explore the different methods and techniques, women come in and they have music and lighting and aromatherapy and meditation practices that they do, and there's even some what is that called? Hypnobirthing is a new thing that people are doing. I have not had any interaction with hypnobirthing, but supposedly women can be hypnotized into kind of a place of comfort during their labor. So lots of different things that they can kind of investigate and prepare for, and they really do have to be their own advocate for how they want to manage their pain, and then we have to be there to support them. It's self-limiting. Labor pain is not constant but intermittent, so they do get a break when the contractions subside. Towards the end, that's not as true because, that head comes down into that pelvis and you can have pain continuously towards the end. Labor ends with the birth of a baby, so yes, it hurts like heck, but you get a surprise at the end that you've been waiting for 9 months. So, there is a reward for all of your efforts. So the physiological effects in terms of having excessive pain, there's fear and there's anxiety that comes from that, which can actually slow labor. Okay, there's this theory that with labor pain, the fear of the labor pain itself, the anxiety that comes on causes tension in your muscles and within your body, and because of that, your body can't relax and you actually kind of fight the work of your uterus. So as your uterus is contracting and trying to push that baby down, your body is sometimes involuntarily not allowing those changes to take place. So I have actually seen moms who have been like stuck at 4 or 5 centimeters, struggling with labor pain. They finally say, I can't do this and I want an epidural, and then they cruise right along because their body isn't fighting the uterine contractions. So I'm not like an advocate. I don't care if you get an epidural or not, but if you don't get an epidural, there has to be some level of being able to relax with the contractions, even though they hurt so badly. Another effect is that mom's metabolic rate and demand for oxygen increases, and this can cause fetal acidosis over time. So if mom's respirations, as we've talked about, increase for a prolonged period of time, it can cause fetal acidosis and actually have a negative impact on the baby. So we need to make sure that we are decreasing our respirations and not letting mom hyperventilate due to the excess pain. And then the psychological effects, it's all about how what's mom's tolerance for pain and what is her expectation for pain in labor. Where does pain come from? So where does the pain come from when you are having a baby? Tissue ischemia. So the uterus is a muscle. It's just like when you do, bicep curls and your biceps run out of oxygen because they're contracting. What do they convert over to and produce lactic acid, which is a burn. So this tissue ischemia in your uterus, from contraction of that muscle, it causes pain. We also have pain from cervical dilation, so that cervix is meant to dilate, but if it hasn't before, or it's a tissue that is meant to expand, but is painful when it does. Okay, and then the pressure and pulling on the pelvic structures. So you're pushing something the size of a watermelon out of a 10-centimeter hole. So obviously there's going to be strain and stress and movement of, pressure on tissue, bone, tendon that isn't a normal, it's not a normal sensation. And then distension of the vagina and the perineum. Towards the end, when we are pushing, we hear something called the ring of fire. So when mom is pushing and that head is ready to be birthed or crowning, there's something that they experience. It's called the ring of fire, and it is just it's just that. It feels like a burning, fiery sensation in the perineum where that tissue is being stretched to its max. And that is obviously painful, and we also have to educate them while that's happening that they need to push through that pain, because the only way to get it over with is to push through it and to get the baby out. So it won't end until they gather themselves enough to push the baby out. That's usually when you have to have a little heart to heart, come on, get it together, you can do it, it'll be over if you just push. So that can be a little bit of a challenge. I love this picture over here because I think it really shows you, when we talk about putting epidurals and spinals in the upcoming slides, this is where we are, around where we're putting our epidurals and our spinals, and it just shows that nerve pathway is to the uterus. So that's why when we numb these fibers here with an epidural or a spinal, it's taking care of that labor pain. And epidurals sometimes have a really hard time controlling back labor, so there tendency to have difficulty with back labor, but an epidural typically numbs the fibers from the site where it's injected down, so it would also take care of this perineal pain as well. And then take note of this pudendal nerve. Some women opt not to have the epidural, but once they get to that ring of fire, they're like, oh, I can't do this anymore. At that point, it's a little late for an epidural, but we can do a pudendal nerve block, which we're going to talk about. So the perception, I already talked a little bit about this in terms of the perception and the tolerance of pain that moms have. So it depends on how intense their labor is. So although we would like to say, oh, a precipitous labor, get it over and done with, they're usually like a freight train coming at you, as opposed to a slow and steady wins the race kind of approach. If it's spread out a little bit over a period of time and it increases at a slower rate, the pain is usually better able to cope with. You're better able to cope with the pain, as opposed to if it comes all on at once. So slow and steady labor is usually preferred. Cervical readiness. So a cervix that is ready to go into labor or goes into labor on its own is going to do better and be less painful than a cervix that we are trying to make dilate. So for instance, an induction. When we're trying to get you into labor, when we're trying to induce you, that pain is usually worse than a labor that is spontaneous or occurs on its own. Fetal position, we've already talked about how OP positions can be way more painful. Anything besides LOA or ROA can have some more pain associated with it. Pelvic anatomy, so if you have a small pelvis, it can be more difficult and therefore more painful. Fatigue and hunger, so make sure that they're well hydrated, and that we give them anything clear liquids that we can to kind of keep their stamina up, because obviously if you are hangry you probably aren't going to be able to cope with anything very well. So getting it in those calories in the liquid format is really important. And then caregiver intervention. So if they have a good supportive team of nurses and their support person or their labor coach or their doula or their sister or their mother, whoever they have, they are bound to do better and be able to cope for longer than someone who does not have good support. Psychosocial factors that come into play. Culture, so different cultures respond differently to labor pain. Anxiety and fear, so how much anxiety and fear you have related to it. And I'd like to say, as they have more births, so a multip would have less fear of anxiety. You usually, that can be the case, but that's usually not the case. Actually, they know what it is and they're still scared, because they're like, oh, now I know what to expect. And sometimes their anxiety can actually be worse the second time around. It's kind of like a PTSD effect. Previous experiences with pain, we talked about that already. Did they prepare? Do they have any tools in their toolbox to kind of face it? And then their support system. So again, having somebody there with them that is going to help. So different types of techniques. We talked about relaxation and meditation as a tool in their toolbox that they can use when dealing with labor pain, and how relaxation is really important to allow cervical dilation to occur. Cutaneous stimulation, so there's something called the gate control theory, that if you're doing so cutaneous meaning skin stimulation. So there's something called effleurage, where you kind of move your fingers around the belly. The mom can do this herself. And those signals that are picking up on that touch that mom is doing on her belly, her pregnant belly, are said to be blocking pain signals that are being sent from that same area. So if you are so it's kind of like when your grandpa used to say, if you hurt your foot, he'll say, oh, we'll step on your other foot and it'll cause less pain in the initial foot. I don't know if anybody else's grandpa said that, but it was always a joke in my family. Because if you have stimulation somewhere else in your body, the initial pain is perceived as less. So that's that whole method behind the gate control theory and kind of blocking pain signals. And then hydrotherapy is a great option. We let them get in the shower, we let them get in the tub, and that is usually very soothing to them. We can dim the lights. It's a little bit more like a spa. There are additional assessments as a nurse that we have to do. We can use a Doppler, underwater Doppler, in order to check the fetal heart rate. We're assessing mom's temperature. The water can't be too hot because you don't want to cook the baby. I know that sounds funny, but if you raise mom's temperature, you're going to raise the baby's temperature. So hydrotherapy is a great option, I think, for helping with pain control. And then mental stimulation or distraction. People play cards, people watch TV, people listen to music, talk to their family members, and then again, breathing techniques. So these are all non-pharmacological ways that you can avoid pharmacological pain management. So these are all options in order to, kind of get through labor and cope without further intervention. So those interventions are usually provided in childbirth classes. The ideal time to prepare for labor is before labor. So in those childbirth classes, it's a great thing. And, moms are usually reading up on books, they're looking on the internet and, looking for ways to cope with labor pain. Support person, it's good to have them, up on what mom wants before they go into that room so that they can kind of be on the same page. We teach and reinforce as much as we can during, but again, it is hard to teach somebody who's in significant pain. Latent phase of labor is the best time for intrapartum teaching. If you want to circle star smiley that's really important. That is the most appropriate time to get mom her education if she needs education about her labor, because she's still kind of herself. She's got that period of rest, a longer period of rest. Her contractions are not as strong, so she's ready and able to talk to you, which is a really good thing. So there are many advantages to using a non-pharmacological method of pain management during labor. It doesn't slow down your labor. There's no risk of any allergies or reactions. The only thing is that some methods may not eliminate labor pain. That's not really an advantage, that's a disadvantage. But it doesn't eliminate labor pain entirely, obviously. And it may be the only realistic option for advanced or rapid labor. So sometimes people come in and they're like, I want an epidural, but there's not enough time for that. So it might really be the only option. The desired pain level is usually not achieved with non-pharmacological pain management. I guess it depends on the expectation of the patient, whether or not they are, if you're expecting really terrible pain and you're prepared to deal with that, then I think you're in a little bit better of a place to use this non-pharmacological method. But even those who are really well prepared and they insist that they don't want an epidural or any other kind of pain management, they are sometimes surprised at the level of pain that they experience, and they change their mind. So I never make that whole deal with people where they say, oh, even if I'm begging for an epidural, don't give it to me, I don't want it. I don't like that because that's not really what I can do as a nurse. If someone is telling me, I changed my mind, I want an epidural, and you've told me not to let you have one, I really can't do that. So I always tell them that I will, remind them of that decision when they ask me for an epidural. I remind them that was not what they wanted, and we kind of they're usually the support person. I let talk them in or out of that decision, just because I can't refuse someone pain management that's begging for it, even if they've told me not to give it to them. Okay, so pharmacologic pain management, there are effects on the fetus most of the time, either directly or indirectly. We'll talk about that. There can be changes in maternal physiologic processes. It can affect the course of the labor. There can be certain complications from each type, which we'll talk about as we go through them. And you have to be careful because there can be interactions with other substances if mom is taking other substances. So different types of analgesia may interact with the substance that they're taking. So we need to make sure we're doing a thorough history. So an epidural is what we're going to cover first. This is a regional pain management method. It's an injection of a local anesthetic into the spinal column, and it numbs from that point down. Sometimes they combine it with an opioid into that epidural space. Sometimes they don't. I think they work better if they do combine it with an opioid. They provide a very significant amount of relief, typically if they're placed appropriately from labor pain. They are harder to get control over back pain when you are in labor and you have an epidural. The epidural doesn't tend to usually cover that back pain as well. Think about that picture from previous slides of, what nerves are covering what areas of the body. So one of the big risks with an epidural is that it works by gravity. So if you lay a patient flat, the epidural can actually migrate upwards. The medication can go higher in the spinal column and numb nerve fibers that are higher, which the next level up is usually the respiratory nerves, which would cover, nerves going to your lungs, which sometimes can make people feel like they can't breathe. So that is a significant issue that can happen with an epidural and that nurses need to be aware of in relationship to positioning their patient. So although, we'll talk about the process of placement. You usually lay them flat for a period of time after, so that flat with a bump to the left, usually, meaning we put them kind of a little tip up to the left just to get the baby off the vein there. And that usually helps to distribute the epidural evenly on both sides. But after that initial 20-minute period, you want to kind of sit them up at a 30-degree angle or so, just so that the level of the epidural does not rise and they don't have those respiratory difficulties. So if you had a patient after their epidural was placed that was complaining of shortness of breath, heaviness in their chest, difficulty breathing, that would be a significant side effect of having this epidural. This is analgesia rather than full anesthesia. So you are awake, aware. It does not affect your cognitive ability. It just numbs those nerves. And it is usually they have good motor movement of their lower extremities, even though they are numb. So a good epidural, they get good pain coverage, but they can still move. Not to the point where they can get up and out of bed, but they can move to help themselves reposition. Some epidurals are really dense and they completely numb them, and then we are moving them physically. And that's a little bit difficult because if there's a complication with the baby and we need them to reposition, we're actually physically lifting the patient, and we usually, you have to call out for help. You can't do that alone. So this is just showing you where an epidural is placed, just so you know where, what it looks like internally. They use the needle to place, so on the picture on the left, you can see there's a needle there. They thread the epidural catheter, much like an IV, placement. They thread the epidural catheter through that needle, and then they remove the needle and leave the catheter in place. So an epidural is left in place throughout your delivery. There is no time frame in which you can or cannot get it. We recommend that you wait until you're in active labor, but we certainly give epidurals out sooner than that if people need them. And there isn't a point where you're too late. Aside from, are you crowning, or you're ready to push and that baby's coming. We give primes epidurals when they're 9 centimeters. So that whole kind of thing where there's like a window of time, that's a little bit old school. And you may have heard that, oh, they missed their opportunity to get an epidural. That's not the case anymore. So when we talk about the technique for epidural placement, the patient has to, usually I tell them to give me a good half an hour prior to them like really wanting to be comfortable, because that's about how long it takes to get anesthesia there and get it placed. So I always say, when you're a half an hour away from being done, you need to tell me, which is really hard to determine, but it's kind of, we laugh about it. So I usually, as the nurse, they'll request the epidural. The first thing that I do is I will increase their IV fluid rate. I want to get 500 mLs of fluid in a bolus format, so in a fast format, prior to them placing the epidural. So that epidural, it can drop your blood pressure. And the way that we combat that is by giving them that extra bolus of fluid beforehand. So that hopefully will keep their pressure up. After I start their fluids, I go grab Bicitra, which is a medication that is, it neutralizes the acids in their stomach. It's a liquid. It tastes like a Sour Patch Kid or worse. And it prevents any kind of aspiration if in the event that the epidural didn't go well and we for some reason had to intubate. It would prevent aspiration of stomach fluid into the lungs. So I go grab that, and then I come back and I educate the patient and tell them what to expect. So what they would expect is the doctor to come. The doctor's going to do an informed consent, so explain the risks and the benefits of the epidural. So the biggies for in terms of risks that we cover are bleeding, infection, and of course, very rarely, paralysis if it is placed incorrectly. The other thing that we mention is the idea that they could get a headache afterwards, a pretty significant headache, or a spinal or epidural headache. After they give consent, we get the mom to the edge of the bed, sitting in a sitting position. As the nurse, you're going to stand in front of her and you're going to help her get into a C position. So I always tell them a C position, they need to curl. So they kind of curl around their baby and hunch over. And they drop their shoulders. So it's like it's like a slouch slope position. So curl around their baby, make a C with their spine, and then drop their shoulders down. We do a timeout. So they get into position, we do a timeout. What's your name and date of birth, and what are you having done? They answer, and epidural. I explain to them that once they're in that C position, they have to try and move as little as possible. It's really hard for somebody who's in labor and having contractions, so we really try and coordinate with the doctor to do this as quickly as we can in between a contraction. Easier said than done. So once they're in that C position, and we've done our timeout, we also put on a blood pressure cuff and an O2 sat monitor. We take their blood pressure every 3 minutes throughout the procedure, and we continuously monitor their heart rate and O2 sat. I am documenting as the nurse when they get to the edge of the bed, when they have when the informed consent was signed, just every step of the way. When was the timeout done? all of those. And then I explain to the patient that once they're in that C position, they're all set up. They've got their blood pressure cuff on. They've got an O2 sat monitor on. I'm going to hold their hands and probably also either their hands or their shoulders to help them kind of slouch into that position. And the physician behind them will inject a local anesthetic for numbing. That's like a bee sting. So, that is really what hurts the most. After that, we let that sink in for a minute and take effect. We do, then the physician will insert the needle, which they feel a lot of pressure because they're putting that needle in between spinal, like their bones of their spine. So there's a lot of pressure and it can be pretty uncomfortable. Not hurt wise, but just very uncomfortable. If they feel anything sharp, you should instruct them to tell you because they shouldn't feel anything sharp in their back. So they place it. It doesn't take very long to place. It takes longer to set up. And then when it's being placed, it's important to tell them if they feel anything sharp, they need to tell us. And we also tell them that if they feel like a funny bone sensation, like an electrical kind of sensation, that is completely normal. It's the needle or the catheter touching those nerve fibers, which is a very strange sensation. And they place that, they remove the needle, we tape the patient up, we give them what's called a test dose, which it's a test dose to make sure that it's in the correct place. They give them a little bit of the medication and they look for an increase in the heart rate and a metallic taste in their mouth. Those are the two signs that they may have advanced it too far and it might not be in the right place. So we do that test dose. I'm documenting when that is done so that we can indicate, see if there's any increase in that heart rate after, in the maternal heart rate after. Continuously through this whole process, you have to try and monitor your baby as well, which is a challenge, okay? So once we do the test dose and they pass, we lay them down with that little bump to the left-hand side, and we let that work by gravity so that the medication is evenly distributed on both sides of the mom's body. Sometimes if this isn't done correctly, or if the catheter is placed to one side or another, like it can be kind of more towards the right or the left side within the spine, you'll get better coverage on one side or the other. And we call those like windows of pain. They'll have like windows of pain on the right or the left. So we watch out for those and we let the anesthesiologist know. Anesthesia hooks them up to a continuous pump. So they continuously get medication through that epidural catheter. And they are more effective when you first get them because labor pains aren't as bad typically when you first get it. And then as your labor continues, you get into transition, you might have less coverage from the epidural. So I do teach them that as well. Like, just because you feel good now doesn't mean that as your labor progresses, your pain might become higher and the epidural might not cover it as well. Our goal is usually to get them below a 4. So once they lay down for that 20-minute period of time, the other thing that we have to do is place a Foley because they no longer have the sensation of when to void. And we need to put the catheter in. So I usually wait till they're good and numb and I put the catheter in so that they don't have to feel it. And then they just labor on, and as a nurse, you are really just observing their pain control with the epidural, their respiratory rate, because we don't want that migration of the epidural to happen up higher into the chest cavity. And we are also monitoring very closely for hypotension. So when I said that some medications, some pain management methods don't impact the infant or the fetus directly, the epidural is what I mean. So the epidural medication does not get to the baby at all. So that's a good thing. There's no respiratory risk in terms of delivery for the baby. But if mom suffers hypotension, she's not perfusing her uterus as well, right? So that baby is not going to be as well perfused, and you might have a decel after you put in your epidural. So that is very common that you have a decel after your epidural, and it's usually a prolonged. It goes down, and then we bolus more fluids. Hopefully, the fluids you gave beforehand were enough to combat that from happening, but it may not be. So we have to troubleshoot that afterwards. Sometimes we have to call anesthesia back, and they'll give ephedrine to increase their blood pressure. We usually can troubleshoot that okay. It doesn't usually wind up in an emergency situation or the OR. We can usually fix it. Bladder distension is another adverse effect. So again, we put in the catheter so that they can void. The catheter comes out before they push the baby out. There is studies that indicate that epidurals can slow labor and prolong the second stage. I think it's more related to the fact, okay, in terms of slowing their labor, we give them a bunch of fluids. So what does that do? It hemodilutes the oxytocin in their system, and it can space out their contractions. So yes, can it slow your labor from that perspective? Absolutely. If you are in good active labor, it will likely slow it down for a period of time, and then once those concentrations of oxytocin are built back up in your bloodstream after we give you those fluids, it tends to be fine. Prolonged second stage, meaning pushing, the reason that that is prolonged is because sometimes those epidurals are so dense that they cannot feel when they need to push. So we might, back the epidural off so that they can feel a little bit, so they have a good idea of how and when to push. Because pushing is sometimes a little bit of a learning curve. The catheter can migrate, so if the catheter moves at all in one direction or another, or pulls out a little bit, you can, the effectiveness of the epidural may be decreased. They do correlate higher risk of cesarean birth related to epidural placement, probably because of that difficulty pushing. But my answer to that is just back off on the epidural a little bit. And then maternal fever. So this is really important to know that an epidural that has been in place for greater than 12 hours, there is a chance that they can develop a fever after that point, and it's an epidural fever. It's not an infection fever, but we need to make sure, just because they have a fever and we can kind of attribute it to the fact that they've had an epidural for a long period of time, does not mean that we do not assess for other signs of infections in that intrapartum mom. Moving on to a subarachnoid block or a spinal, which is what you more commonly would refer to it as. A spinal procedure is exactly like an epidural procedure, aside from the fact that the difference between an epidural and a spinal is a one-time injection. So there's no catheter left in place. They inject, they insert a needle, but they don't put the catheter in. So they give you one-time dose of the numbing medication. It lasts for about 2 to 3 hours. There's two places for this that we use this. If there's a multip who is, imminently going to deliver, we think that she will deliver within the next, 2 to 3 hours, we will give her this instead of an epidural, because the spinal, it's a one-time shot again, so less risk for infection as opposed to an epidural catheter that's left in place. Really only 2 to 3 hours would be necessary, as opposed to needing it for a longer period of time. And then we also give this in situations for C-sections. Now, for both this is a circle star smiley concept, for both a spinal and an epidural block, neither one of them can be performed if platelets are below 100,000 or 100. We usually shorten it up to 100. So 100 or 100,000. That's what we mean when we say, usually you don't discuss it in 100,000. And usually We are anything below 100 for platelets in a CBC. We would not give them an epidural or a spinal because of the increased risk for bleeding. They don't have enough clotting factors for it to be safe to administer. So if someone comes in and we do their CBC on admission and their epidural and their platelets are below 100, they are not a candidate for an epidural. And if they go to the OR, they are not a candidate for a spinal. So they need to have general anesthesia. So that's a big thing to remember for both an epidural and a spinal. Sometimes the spinal can migrate up as well, but again, it's a one-shot deal, so it usually just coats it, numbs it for that period of time. You don't see as much migration upwards to affect the respiratory center as you would in an epidural over a period of time. So positioning in the OR, for instance, for a spinal, we still lay them flat for the entire duration of their surgery. I think it's the next slide. There's a picture of the difference between the coverage of that we provide for a spinal for the OR and an epidural or a spinal for a vaginal delivery. So I'll show you that. So this is the level for a C-section, so around T4 to T6. You don't have to remember that, but this is just a nice visual. And then T10 through S5 for a vaginal birth is usually what we cover. So even though with the C-section it doesn't tend to migrate up further, you can see that we do protect them up to the nipple line. So just by the sheer idea that you're starting higher, you can affect those respiratory nerves that are supplying those lungs. So you can sometimes have women who feel kind of that heaviness or difficulty breathing with a spinal. So these are the two different images for that. So a dural puncture would be the spinal headache or the epidural headache where they've advanced that needle too far. It's postural, so when they lay down, it equalizes out that pressure like we've talked about in the postpartum section, because this is when they experience it, is in the postpartum time. If they lay down, they feel a heck of a lot better. They can't sit up. It's an excruciating headache. Hydration and rest is usually what's prescribed. If it's very significant, we give them a caffeine drug. It's called theophylline, and then we can also perform a blood patch procedure if need be, where they take that sample of blood from a peripheral artery and then inject it into the space to form a clot over that puncture to stop cerebrospinal fluid from leaking. So that's I don't feel like we need to go too heavily into that because we did cover that in postpartum, but it needs to be here as well because it's related to epidural and spinal management. So moving on to systemic drugs. So systemic drugs, we are predominantly talking about IV medications and analgesia. The difference between this category does affect the baby. So that's an important thing to remember because it is going systemically through the mom via her blood system. Vascular system. That was really bad. Stadol and Nubane are the two that you really need to know. They're both IV medications. Stadol is the one that is most commonly used. And it's given IM and IV. So we usually give 1 milligram IV and 1 milligram IM. We give the IV first to give them good pain control initially, and then about 5 to 10 minutes later we'll give them the IM dose because that will last over a longer period of time just by, in the difference of the routes. So IV is going to take effect quicker, and then the IM will take a little longer to be absorbed and distributed to take effect for a sustained period of time. The important thing when we give Stadol and Nubane to mom is to know that it does get to the baby. So baby can have respiratory difficulties if we give Stadol or Nubane too close to delivery. So for that reason, we make sure that we do not give either of these drugs after the mom is 6 centimeters. So these are a good option in that latent phase of labor. to kind of get mom over the hump and give her some rest. A lot of people will try this. They don't particularly love it because it doesn't necessarily take the pain away, but it makes you not care that you're in pain. You kind of feel like you're drunk. So for that reason, some precautions that we need to take when mom takes Stavadol or Nubane is that she needs to be on the monitor because we need to monitor that baby. She needs to be in bed because she won't be steady on her feet. And she's a huge fall risk at that time. I don't usually leave them alone. I make sure either I am in the room or their support person is in the room and they can't leave. Another thing is, because it does get to baby, and like I said, we can't give it past 6 centimeters for fear that the baby will have respiratory distress at delivery. The other thing is, when you give this medication, it is expected that your fetal heart rate variability is going to become minimal. So it's definitely expected that that would happen, but it doesn't mean that if you have it, that you're not going to do something about it. So if your fetal heart rate variability decreases to minimal, you might want to reposition mom to a lateral position, give her oral fluids if she can have oral fluids. I wouldn't necessarily say to initiate a bolus at that point because you don't want to space out her contractions. And we know that this Stadol and this Nubane is what's causing that minimal variability. But you would, try and improve it by repositioning at least. The other thing is we want to have Narcan on hand for both mom and baby. It's a suppressant, so they could potentially have respiratory issues from this. Most of the time that's not the case. And it's more important that if, suppose you give the Stadol and then mom dilates rapidly and delivers within an hour, while the Stadol or Nubane is still in effect, you would want to have Narcan doses available to give to the baby to reverse the effects of these drugs. Again, it's a sedative, so you want to be watching out for respiratory distress in mom as well, but it's not as common. It's more important for the baby for that we see this change. Nitrous oxide is another option, and this is not used in every facility yet. We are using it at Saratoga. It's been used in Europe for a really, really long time to help with labor pain. So nitrous oxide is basically laughing gas, what you get at the dentist. It's really, really helpful. When I've had women use this in labor, that it is very beneficial. They can use it during any point of their labor, and also they can use it for repair afterwards. So suppose, they don't want an epidural. It is systemic, okay? So it does get to the baby, but the difference between the inhalation of nitrous oxide and the administration of an IV medication like Stadol and Nubane, sorry, is that this nitrous oxide has a very, very fast half-life. So within 1 to 2 minutes, mom's, it's been processed and there's essentially no impact on the infant within a couple minutes. So it's really safe to use the entire time. How we initiate it is it has to be a one-on-one nursing care situation. It's self-administered by the patient. So we bring it in to them. It's 2 big canisters and connected to a face mask, and they self-administer it. So as they start to feel the contractions start, they start inhaling the nitrous oxide, and usually it starts to take effect and they kind of will remove the face mask by themselves because they just don't have the energy to hold it up anymore because this medication is taking effect. And then by the time the contraction is over, they're kind of back to themselves. So it's a very quick, it kind of helps relax them. They do have to be continuously monitored on the fetal heart rate monitor during its use. And it's also important to know that we have to stay in the room while this is being used because, believe it or not, we have people who try to give it to the support person. So you can't leave them alone. And it's important that if the nurse themselves is pregnant, they cannot administer this to a patient. So you would have to choose appropriately who was going to care for that patient based on that status. It is not, it's okay to a baby in a third trimester at delivery, but we do not want, increased exposure to babies in utero prior to that. But this is very safe. It's a great option, like I said, at any point in time, and we've seen really good results with this. Women being able to get further and further into their labor before they either request an epidural or they wind up not needing to request an epidural at all. So good things are going on with this nitrous oxide. The pudendal block. So this is old school. I don't see it very often, but when I do see it, I think it works really well. And I think it's kind of like a dying art, like doctors aren't doing it anymore. So I think they're a little bit afraid to do it. Don't, I just don't think that people think of it as a great option anymore. But what it is it numbs that nerve to the perineum. So if they make it to that 10 centimeters and then they're afraid of that ring of fire, we can do a pudendal block where we numb that entire nerve, and they can push through that ring of fire a little bit better. It can give anesthesia for an episiotomy or laceration that may occur, so that's a benefit as well. It does not block any pain from uterine contractions, but again, it will help numb that perineal area just for delivery. And mom will still feel pressure, but she won't feel, hopefully, the pain. The pain sometimes is just as uncomfortable as the pressure, though, I will have to say. So this is where that pudendal nerve is, and I know it looks really big and really scary, and I think it does take a skilled physician to do it. So I think that's why they don't do it anymore. Not to say that I just don't think it's offered, and I do also think that people get epidurals. So a lot of people who are getting epidurals, they don't need this because they're already numb in this way. So sometimes, there's a lot of factors that go into why this is kind of died out as an option. General anesthesia, which is used for C-sections. This is systemic pain control. The baby is affected. Mom loses consciousness. She needs to be intubated for the duration of her surgery. It's rarely, I want to say never, used for vaginal births, okay? In the old days, yes, they used to knock people out, but they don't do that anymore. It does have a place in cesarean birth, as I said. It can be used in an emergency situation as well. So suppose you have somebody who's 4 centimeters laboring along, their baby, they have a prolapse cord. They rupture their membranes and they have a prolapse cord. You are rushing to the OR. You may not have time for a spinal placement, so they would put you under for general anesthesia. So in emergency situations, if you're rushing to the OR, you may need general just for the sake of time and getting that baby out safely. If this is just to show you, if you are the nurse assisting during a C-section, this is called cricoid pressure. So you can see from this image, you kind of put pressure below that Adam's apple and it closes off the esophagus to intubation. So as the physician is intubating, they may have you apply pressure there so that they can place the tube correctly into the trachea. So that's all that is, but as nurses in the OR circulating, like we do, this may be asked of the OB nurse, the circulating OB nurse. Okay, so changes from normal labor. We are going to talk about a couple things that could potentially happen. Aversion is one of them, and I will say that the external version is way more prominently used than an internal version in the situation where there may be twins. So this is just kind of as an aside. This is what I want you to focus on. Aversion can be used if a baby is male positioned, like a breech, a transverse, a shoulder, or oblique presentation, we can push on mom's abdomen externally and try and reposition that baby to a cephalic head down position for delivery. So this is used a lot of times in, it can be in primes, but mainly I see it in multips who've had a successful delivery vaginally in the past. Then they have a second pregnancy and their baby is breech, and they don't want to have to go to the OR because they do have a proven pelvis, and we can attempt to flip their baby around for them so then they can deliver vaginally in a cephalic position. So these are all the contraindications to having aversion. So if you have any of these, you cannot have, you're not a candidate for aversion. So any problems with the uterine shape, there are different shaped uteruses out there. Any previous history of a cesarean birth, that provides a section of scar tissue. So we would not want to be aggressively pushing on that uterus where there was an area that was weakened because there was a scar present from a previous C-section. Any problems with the placenta, so placenta previas, placental abruptions, anything like that. Cephalopelvic disproportion. So if we know that this kid has a huge head, it doesn't really make any sense to turn the baby and try and make mom deliver vaginally. So that would be more so in the instance of a primate, because if we know that this child is very large, the chances of a successful vaginal delivery are pretty low anyways, so we wouldn't put her through this to then have her deliver via C-section anyways. If you have more than one baby, you can't do an external version. You could do an internal version, which is where they turn the second baby once the first baby is born, because it might not be in the correct position. But like I said, we're not focusing on that. Oligohydramnios, so that's low fluid. If you have low fluid, they will not attempt this on you because there's more, a higher risk of an incident with the cord compression, and there's just not as much wiggle room in there. It's better if they're polyhydramnios because then there's a little bit more cushion and it's a bigger swimming pool to flip them around in. And then intrauterine growth restriction. So if there's an issue with baby's growth, that could indicate an issue with the circulation to the baby, whether it be via the cord or the placenta, and we would not want to further compromise that situation. Risks that can happen, complications are usually pretty low, 1 to 2% suffer a problem. The biggest risks are fetal heart rate changes, and they usually return to normal. We can have a period of bradycardia afterwards just from the change in position that we can fix with repositioning and of mom, bolusing, oxygen, just the same interventions that we would use for any kind of a decel. Serious risk to the fetus would include entanglement in their umbilical cord, very, very rare. Fetal hypoxia, if they were to have that bradycardia afterwards, and then there is a potential for a placental abruption. Again, very, very low risk of all of those. Maternal sensitization to fetal blood type. So they would also be given RhoGAM if they had aversion, if they were Rh negative, if mom was Rh negative, because when you're pushing around on that belly, there can be some fetal maternal blood mixing, which if that baby winds up being a Rh positive, then mom could develop those antibodies to attack that baby. So you would want to give mom RhoGAM at this time as well. So what we usually do for aversion, we bring them in. We give them an NST or a non-stress test just to make sure that the baby is doing well. We put them on, make sure the variability is good. They have ACT cells present. Make sure the baby's healthy before we do anything. And then we admit them for a period of time. Usually we want to make sure that we are doing this prior to 37 weeks so the baby's not too big to turn and there's more room and more space. We give them terbutaline, which is a tocolytic. Okay, that's a fancy word for drugs that relax the uterus, and that would be Terb. We would give them terbutaline beforehand. We do ultrasound guidance. So we use the ultrasound to find out where the baby's head is and bottom is, and then the physician will apply their hands to the abdomen and manually move the baby under that ultrasound guidance. Again, we would give ROGAM if needed. One of the things is this can be pretty painful, so sometimes patients will opt to have a epidural placed for this procedure. We give them the epidural, we flip the baby, we take the epidural out, we let their legs return to normal, and then we discharge them. So the goal of this is to flip the baby and send them home so that then they can come back later in spontaneous labor, which means labor that happens on its own. If they are not successful in flipping the baby to a cephalic position, then we bring them back in. We schedule their C-section at that point because we don't want to have a breech delivery. So 2 options that can happen. They don't have to have an epidural if they opt out of it and they want to kind of grit their teeth while they do the procedure. I know that sounds awful, but there are patients who prefer that. Other patients prefer the epidural, and whether or not they flip depends on the course of action afterwards. So if they flip, we send them home and hopefully go into labor. If they don't flip, then we send them to the OR and schedule that for a later date, after 39 weeks. So our job, what are we doing? We're providing information and education from the moment that they come in, and kind of just letting them know what's going to happen. We are assessing mom and baby the entire time. They have to be on the monitor, so we're looking at that very closely, and then reducing anxiety the best that we can. Like I said, it is pretty painful for some people, but the level of pain also is impacted by how easily this kid is going to turn. So if it's in an oblique position, it's easier to get that kid down as opposed to a complete breech position. Okay. And also, is the baby big? Is there enough fluid? All of those kind of play a role into telling us how difficult this is going to be to do. So we prepare them, but we don't scare them. Okay, so now getting into induction versus augmentation. We talked about the difference between those two, but just as a review, induction is when you're starting from scratch. There are no contractions happening, there hasn't been any cervical dilation, there is no labor happening at this point, but we need to get this person delivered for one reason or another. Usually it's a medical induction. We try and get people to 39 weeks if we can, but if they have things, such as preeclampsia or maternal diabetes, we really want them to get them delivered. So those would be instances that we would deliver them prior to 39 weeks with an indication, so a medical indication, and then we also induce if they are past their due date. Usually around 41 weeks we will schedule people so that they deliver by 42 weeks because that placenta is starting to get old. Reasons why you wouldn't induce somebody: fetal macrosomia, so known fetal macrosomia, we would rather have those people go into labor on their own. Macrosomia is a large baby. It's a baby that's greater than 4,500 grams. So if we know that that baby is big, then we usually don't push the labor thing. It should kind of go on. We like them to go into labor on their own. Other contraindications would be a past uterine surgery. So anybody who wanted to VBAC or have a vaginal birth after a cesarean section, suppose they had a C-section for their first child and now they want to have a vaginal delivery, we don't recommend that they be induced. So they can go into labor on their own, but induction is not favorable. Just because you're putting stress on a uterus that is not a natural stress, whereas normal labor, that we aren't doing something or putting something into their body to make them have contractions, is a lot less, it's more slow and steady, as opposed to induction kind of, it throws people into contractions quite quickly in some cases, and puts added stress on that uterine muscle, which then has a scar on it if you had a C-section in the past. Augmentation. So augmentation is changing someone's labor, someone who is in labor and their labor has slowed down, and we want to give them something to make it go faster, or they've are not making fast enough progress. So maybe it hasn't slowed down, but they just aren't really moving along from the beginning as quickly as we would like them to. Especially in the event that, there was some fetal indication as well to kind of move the labor along. Another reason would be if they were ruptured for a long period of time. We don't want them, we wouldn't do anything, and they don't do anything for prolonged ruptured membranes, but, we don't want them, the longer they're ruptured, the higher the risk of infection. So we do want to get them delivered, but there's not really a time frame on it. Just kind of move it along. And like we said, the average is after 6 centimeters, you should be going at least a centimeter an hour. So if we're not meeting that, sometimes we will intervene and augment their labor. So, risks of induction and augmentation: you can have excessive uterine activity because we are giving them a drug to stimulate their uterus, so we can overstimulate it. We're very careful about that, so we'll talk about that a little bit more. You can have uterine rupture if you're stressing the uterus too much. But again, we monitor that very closely. We're palpating constantly. We're measuring to make sure that they have enough of an interval in between to give their uterus rest and their baby rest. Another risk is chorioamnionitis, which is an infection. So inductions tend to be very long compared to spontaneous labor because it can take a long time for the body to respond to the medications. So that just puts them at higher risk for an infection within their uterus while the baby is still in the amniotic sac. So that's chorio, which is an infection during labor, so an interpartum infection. And then they're at higher risk for cesarean birth because, again, it's like trying to throw, so a cervix that goes into labor on its own is going to be soft and pliable and amenable to the fetus's head opening up the cervix and dilating it and effacing it. But if you're trying to induce a cervix into being in labor, it's like throwing a tennis ball up against a cement wall because it doesn't want to open. So they are at higher risk for going into C-section, or going to have a C-section. Also, it's important to note that it's harder to get people into labor the earlier they are in their gestational age. So if they're preterm, they're going to be harder to induce even on top of that. And then postpartum hemorrhage, and that has to do with the length of time that inductions take as well. So the longer your uterus is working and trying to contract and open up the cervix, the harder time it's going to have after delivery contracting down to stop them from bleeding. So it has to do with the length of time that they are contracting, and it's usually a lot longer for an induction. And we're talking like days sometimes that this happens. A 2 to 3 day induction is not necessarily uncommon. So different techniques that we use. The first thing that we usually do, and we do this for all labor patients that are admitted, we do something called a Bishop score where we assess their cervix. It takes into account their dilation. Is it soft? Is it anterior or is it posterior? So anterior means it's towards the front of mom. Posterior is towards the back or mom's bottom. And when the cervix is posterior, it's less likely to be ready to go into labor. So a Bishop score is just determining whether or not a mom's cervix is ready to go into labor. And that number that they are given, based on those different categories that we just mentioned, help to determine how easy it is going to be to get a mom into labor. So the lower the number, it's out of 10, and the lower the number, the harder it is for them to get them into labor. So they get more points for being more ready to go into labor. So if they have a Bishop score of like 2 or 3, it's going to be a long haul. If they have a Bishop score of 6 and above, it's typically not as difficult. Cervical ripening. So cervical ripening is a method of softening the cervix via pharmacological methods. So we pharmacological methods and also mechanical methods. So there's two different means of doing it. The pharmacological methods are Cytotec and Cervidil. So Cytotec is a pill, and it's inserted up next to the cervix, and it dissolves. And that is, they're prostaglandins. Both Cytotec and Cervidil are prostaglandins, and they soften the cervix and get it ready for labor. So a lot of times with primips, we will bring them in the evening, the night before, and we will do Cytotec or Cervidil and get their cervix into labor. So Cytotec is the pill. Cervidil is usually preferred because it looks like a little tampon, and you put it up next to the cervix, and it's got a string attached to it. So Cervidil is a little bit more, is safer because it doesn't dissolve and go into the bloodstream to the point where you can't get it back. So Cervidil, when you pull on that string and remove it, you can take the medication out of mom's system. Cytotec, it dissolves, it's absorbed, and it's there. It's acting. So these two, again, are used to soften the cervix, and Cervidil is usually preferred because you can stop it. So suppose you put in Cytotec and that mom starts contracting away, you can't get it back. You've got to either, and potentially they could be contracting too much, and they could have hyperstimulus or what's wrong with me? Tachysystole. They could have tachysystole with their contractions, and then you'd have to administer terbutaline to slow them down if baby was having difficulty or they were too close together. Cervidil, you just pull it out with a string. So again, Cervidil is preferred over Cytotec. Cytotec you will see again when we talk about postpartum hemorrhage more in depth, because that is also a postpartum hemorrhage medication. Both of these are usually used with primips, and they usually are inserted the night before. Sometimes if you're doing these with Multips, these are enough to actually kick the mom into labor. So these might be the only method that they need in a multipara mom, so someone who has had a baby before. Mechanical methods of ripening the cervix and getting it ready for labor are a transcervical balloon catheter, so it looks just like a Foley catheter, and you put it up in through the cervix, so you have to have a tiny bit of dilation, and you blow up the balloon on the other side of the cervix, and it kind of helps to open up that cervix. Usually they can get them to 4 centimeters with the transcervical balloon catheter. They can also do something called stripping their membranes. So sometimes they do this in the office, and they will kind of separate that amniotic fluid bag from the cervix in a way, and that releases prostaglandins, and that can get them into labor and kind of get things stirring. And then an AROM, so artificial rupture of membranes. You can break their bag of water and release the prostaglandins. So at the top of this slide it says induction and augmentation. All of these methods can be used for induction. Okay, so Cytotec, Cervidil, the balloon, stripping their membranes, and AROM. Augmentation, so to change labor, they can use AROM. So they would not use Cytotec, Cervidil, the balloon catheter, or stripping their membranes to augment their labor. They might use another medication, Pitocin, which is what we're going to cover in the next slide, to augment labor and kind of speed it up as well, but they do not use Cytotec, Cervidil, transcervical balloon catheter, or stripping their membranes to augment their labor. They only use those to induce them. So oxytocin can be used to induce and to augment. So remember how we said the Cytotec and the Cervidil, we would bring them in the night before. So Usually the course is you come in the night before, you have Cervidil Cytotec right in the cervix, and then the next morning they start you on oxytocin. Oxytocin can also be used to augment people who are in labor but have slowed down and they just need a little bit bigger boost of oxytocin in there. Or Pitocin, they're used interchangeably. To increase the speed of their labor if they've already been in labor, but it's slowed down. I kind of broke mid-sentence there. I apologize. So oxytocin is given in an isotonic solution. It's usually normal saline, and it's usually in it. Now this is up for discussion too. Not discussion, but in different hospitals they're doing different things right now, and I don't know why they aren't all on the same page. Some places are doing 1,000 bag with 20 units in it, and some places like Saratoga, Glens Falls, they're doing, I think Saratoga's doing a 500 bag with 30 units in it, and Glens Falls is doing a 250 bag with 30 units in it, I believe. I'm not positive about that actually. But and the reason why so that those are differences in concentration, and that makes a difference in terms of how many mLs an hour you're increasing it by. So we'll talk about that in a second. It's always run as a secondary in a piggyback infusion. So you have a primary with a pump, and your primary is hooked up through the pump, and then you have a secondary, so you have two pumps. You have your primary with a pump, and then you have your Pitocin as a secondary into its own pump, and then piggybacked into the primary at the port closest to mom's site of infusion. So it's on its own pump, different from the primary pump. So it's kind of like a piggyback, but you're piggybacking it through its own pump. You have to insert oxytocin into the primary line. You can't run oxytocin alone. It has to go into that, be connected to that mom at that site closest to her IV site, and then start slowly and increase gradually. So regardless of the concentration, so it may change the number of mLs that you increase an hour, but regardless of that concentration, whatever number of mLs per hour that it's determined by your facility, we only go up by 2 milliunits per minute. Okay, so we start out at 2 milliunits per minute, which is like a teaspoon an hour, okay? And then every 30 minutes, we can increase by 1 to 2 milliunits per minute until a contraction pattern that is adequate is achieved. So, every 2 to 3 minutes, good resting tone, moderate to strong to palpation. So you're increasing until you get a good contraction pattern. Not everyone will respond to Pitocin the same. So, like I said, 2 to 3 day inductions are not uncommon. You can have women come in, they get Cervidil or Cytotec the night before, they get started on the Pitocin for the next morning, they go all day, and it looks like they might be contracting, but they aren't palpating, and the patient's not feeling a darn thing. Which means they're not making cervical change. So then they'll stop the Pitocin the end of the day, they'll redo the Cervidil or the Cytotec overnight again, start the oxytocin the next morning, and hope that they respond. There is such a thing as oxytocin flooding, so you can flood the receptor sites on the uterus, and after a certain period of time, you can increase by 2 milliunits per minute all you want every half an hour, but those receptor sites are flooded, and you're not going to get a response at that point either. So it's really kind of tricky business to get people into labor sometimes. We can only increase, the highest level we can give is 20 milliunits per minute. If you need to go higher than 20 milliunits per minute, you need to consult the physician, okay? So we only go up by 1 to 2 every half an hour. Slow and steady usually wins the race. I usually even put it off to 40 minutes just because I think I get a better response from patients, but the protocol is every 30. We are monitoring uterine activity, the baby's heart rate, and any like trends in the fetal heart rate patterns. Very frequently, once a patient is on Pitocin, they are a 1-to-1 nurse ratio. We need to make sure that we're observing the fetal response to this medication. Tachysystole reduces placental blood flow, so making sure that our contractions aren't too strong, too close together, and that would be evident by changes in the fetal heart rate pattern. Reduce or stop the infusion for a non-reassuring fetal heart rate. So remember when we talked, last week about late decels, variable decels, or decreasing variability. Any of those things may require us to stop our Pitocin or our oxytocin infusion. Now, we would always perform our interventions first. So reposition, bolus of fluid, give them their oxygen. If we can't get them to slow down, if we can't get the contractions to slow down and the fetal heart rate to respond and come back to a reassuring pattern with good variability, accelerations, then we need to turn off our PIT. The other time that you need to turn off your Pitocin is if you can't monitor your baby for some reason. Maybe it's moving around a lot, maybe mom is moving around a lot. This is one of the reasons why we would put in an FSE, because if you are on Pitocin and you can't monitor your baby, you can't be on Pitocin. Because if you're on Pitocin, you need to make sure that your kiddo is okay. Again, you may also require an IUPC if you are inducing someone with Pitocin. Suppose it looks like you're using a tocotransducer and it looks like they should be contracting frequently and doing really well, but you can't, they're contracting every 2 to 3 minutes. You have a good space in between. They're palpating okay, moderate, but you can't, but they're not making any cervical change. You need to put in an IUPC to verify that your contractions aren't too strong before you increase that Pitocin any further. So that's one scenario that would require an IUPC. Now, if you are, contracting every 2 to 3 minutes and you're making cervical change, you have adequate rest, the baby looks great, then there's no need for an IUPC with the Pitocin because you don't need to increase your PIT anymore. So if the fetal heart rate is reassuring and the contractions are adequate, then there's no reason for an IUPC. If the fetal heart rate is reassuring and the contractions appear to be adequate, but they're not making any cervical change, you want to put in an IUPC in order to verify that they are not too strong and you're not going to stress out your baby. Okay, so if that's kind of an important concept to realize that you may need an IUPC to verify the strength of your contractions before you increase your Pitocin further. We can talk about that in our collaborate sessions this week too. I think that's a really important thing to understand. It's good to put mom in a side-lying position as much as possible to increase blood flow to the baby, and then oxygen via face mask 10 liters per minute is also something that we can provide in the event that we have a fetal response that is not reassuring. And we're also need to observe mom's response. So remember I said induction with Pitocin is a little bit more intense because it's like throwing a tennis ball up against a concrete wall. Usually Pitocin hurts more than spontaneous labor. So we're assessing mom's uterine activity, we're assessing her blood pressure and pulse continuously. We are aware of different pain management techniques, and usually, if you have to be induced, your plans for maybe a more natural approach without an epidural, it might be a little bit harder to accomplish because those inductions tend to be more painful. We want to record their intake and output, observe and assess for uterine atony in the postpartum period. Again, you can flood those receptors if you're using too much. If you're using Pitocin for a really, really long time, a 2 to 3 day induction, it might lose its ability to respond to Pitocin. So when we give every mom Pitocin after delivery to keep her from bleeding, this mom that's had such a prolonged induction may not respond to that Pitocin as they should. So, what's the nurse's responsibility during the birth, like during the final, finale? It does seem so funny, like the first time that, not the first time, but in the beginning when I was started to do this, I always thought, it was the actual birth itself seems very, very short to me. We worked so hard for so long getting this baby out, and then once it's out, it's just like, how did that even happen so quickly? Sometimes we can push for a couple hours, and that can make it feel a little bit longer, but it's really amazing that the culmination of it is such a small feeling in terms of how much time you're in it. But our job is we prepare the delivery table, and that's a sterile setup, so we get to do that with, there's gowns, gloves, drapes. We prepare the instruments for the physician. I usually start preparing my table when my patient is about 6 centimeters, because I feel like at that point you don't know, it could go quickly or it could take a long time. Those delivery tables, once they are set up, are good for 24 hours. They've got needles on them, they've got sutures in them, they've got, any instrumentation that they may need for a delivery. So different types of scissors, different clamps, all sorts of, equipment. Sometimes they ask for a perineal cleansing, but prior to delivery, we currently only have one doctor that does this, and they do a betadine scrub. So they'll just kind of scrub their bottom before the delivery. It helps to hopefully decrease infection, but not everybody does that. We are there to help the mom and the partner with final pushing efforts. We hold legs, we hold the fetal monitor, the heart rate in place so they don't have to have the band on anymore. We are documenting anything that happens, and there's usually a second nurse that comes in for the initial care and assessment of the baby. So one nurse is in charge of the mom, and one nurse is in charge of the baby at delivery. And then we are in charge of giving any medications. It's typically just oxytocin to help contract the uterus and control blood loss. And remember, I said Cytotec is not only an induction med, but it's also a postpartum hemorrhage med. So we have Cytotec on hand to hand to the doctor. We hand them their sutures. And then once the repair is done, we are in charge of taking down the table, cleaning the instruments off, putting them to go down to be cleaned and sterilized for future use. We manage the placenta afterwards and make sure if it needs to go to the lab. Sometimes they test the placenta under certain circumstances. Other times we just have to dispose of it. Or if the patient wants to take it home with them, we can do that as well. And then we clean mom up, clean up her bottom, put an ice pack on there, get her some Motrin. We turn off the epidural and call anesthesia to remove that. We initiate their 4th stage of labor, where they are getting their vital signs and fundal checks every 15 minutes, and we assist with breastfeeding. So this is where you kind of pick up from that postpartum packet that we already have completed. Okay, so in the event that it doesn't go smoothly, and we need to provide that mom with some assistance, it's called an operative vaginal birth when you use a vacuum, okay? So a vacuum extraction sounds terrible, doesn't it? It's helped to shorten up the 2nd stage of labor, or the pushing stage. It's usually used when mom is completely exhausted and not able to push effectively anymore. If there's infection and we need to get the baby out quickly, or if mom has any cardiac or pulmonary disease that we need to kind of rapidly deliver this baby. Fetal indications would be a placental abruption. Now that would be if you were pushing already, the head was crowning, and we detect signs of a placental abruption. and we need to deliver that baby quickly, and it's quicker to put a vacuum on than it is to get them to the OR. So that would be a reason, or any non-reassuring fetal heart rate pattern. It doesn't have to just be an indication that there was a placental abruption. And in order to do this, in order to put a vacuum extractor on the fetal head, and it's exactly what it sounds like. You're applying basically a suction cup to the fetal head and pulling as mom pushes. In order for us to be able to do that, the head must be very low in the pelvis, so at that 0 station or more. So 0 plus 1 plus 2, we can assist them. Above 0, we are not applying we can't apply a vacuum. So cesarean birth is preferable over an operative vaginal birth or the use of a vacuum when there is severe fetal compromise, when there's acute maternal conditions, if there's a high fetal station, which we just discussed, anything greater than, if the fetal head is higher than 0 station, and then if there's known cephalopelvic disproportion or suspected cephalopelvic disproportion. If you think it's just a gigantic kid, you do not want to put a vacuum on. You can cause some severe perineal trauma for that mom, and not to mention you're yanking on a child's head, and can cause some pretty significant issues in baby as well. So the list of risks that are associated with vacuum extraction both have to do with trauma that can be caused to maternal and infant, on the maternal and infant side of things. So the maternal side, laceration, hematoma of the vagina. You can have lasting pelvic floor disorders, anal sphincter disruption, which aka that just means you can't poop normally ever again, and then infection. And then we actually had a patient once that from her first delivery, she lost control of her anal sphincter. Therefore, she was not able to hold stool anymore. She wanted to have another baby, and she opted to have a C-section because she did not want to go through that again. On the infant side of things, you can have bruising, facial and scalp lacerations and abrasions. You can have facial nerve, that shouldn't say surgery, damage. It's damage that can be caused. I'm sorry, that's a typo. Cephalohematoma, subgaleal hemorrhage, which is worse even than a cephalohematoma. Those subgaleal hemorrhages, those are typically, and intracranial hemorrhages, they happen very quickly and babies die very fast. Scalp edema from the vacuum extractor. Now, I will tell you that if they are using a vacuum, they're usually cutting an episiotomy, okay? And in addition to that, if they are using a vacuum, that baby usually at minimum has scalp edema or abrasions. They're, you know, I've seen a lot of vacuums applied, and I've seen them be completely fine. Okay, they help people avoid a C-section delivery as long as they're utilized correctly. We're going to talk about how they can be incorrectly utilized in a minute here, but I don't think that they are necessarily a bad thing. I think they do help people avoid the OR, but you know, you have to use them appropriately and follow the instructions when you do use them. And sometimes it's hard because we're not the ones that are applying the vacuum, we're not the ones performing the procedure, we're the ones that are documenting the procedure. So we don't have as much control over that situation. We really have to be patient advocates when they're using vacuums to help deliver patients. So on our end, we need to prepare the woman. The cervix has to be completely dilated. Membranes have to be ruptured because you're applying this to the fetal scalp. We have to make sure they have adequate anesthesia, if need be. I don't like the idea of applying a vacuum to a mom that is not medicated or has an epidural, it would be very, very, very painful. And I'm trying to think, but I don't think I've ever had a vacuum be applied to a mom that didn't have an epidural. We want to make sure that her bladder is empty. So usually if they have the epidural, they have the Foley. We would remove the Foley before we started with the vacuum. And this bottom part is really the most important part. The cup is attached to the fetal head and traction is applied. There's a mushroom style or a kiwi style. I don't know where the names come from, but it just has to do with the shape of the cup and the method of how it's applied. And only 3, this is the really important part, only 3 pop-offs are allowed. So you apply it, you document when the physician applies it, they push, the doctor pulls, mom needs to push as the doctor pulls. It's not just the doctor yanking on the baby. It has to be a mutual thing. So doctor pulls while mom pushes. Suppose the cup pops off of the baby's head. That's called a pop-off. We document that the pop-off happened. The physician is allowed to reapply 3 times. If it pops off 3 times, then they are not allowed to proceed any further. Now that is where I was trying to say earlier that, we are the documenters and we are the advocators. So after 3 pop-offs, and that we've documented those 3 pop-offs, I've seen physicians do more than 3 pop-offs. Okay, and it can potentially cause damage to the fetal scalp. It can cause damage to mom. There is a reason that vacuum is not doing that baby's not being delivered. There's a reason why that baby's not coming out if you've had 3 pop-offs and it's not out yet. Something is not adding up. Maybe the position is wrong. Perhaps the baby's just too big. That's where you can have that pelvis that's just too small. It gets kind of ugly. So after 3 pop-offs, as the nurse, you are to inform everyone in the room, we've had 3 pop-offs, we can't proceed, and then the only thing you can really do is document and to protect yourself if they continue to apply the vacuum and proceed beyond 3 pop-offs. I usually get my charge nurse involved as well. This is a mushroom style. So that cup is applied to the fetal head, and as mom pushes, the physician pulls and provides traction. It cannot be just a physician effort because further damage can be done. So mom has to put whatever she can into it in order to get the baby out. We have to make sure that we watch these moms for trauma after delivery. So these moms are more prone to have postpartum hemorrhage due to perineal trauma or laceration as opposed to uterine atony. So usually it's not because their uterus won't firm up, it's usually because they have a laceration that's bleeding profusely from the use of, they're at higher risk for bigger lacerations. That's what I'm trying to spit out. So if you have bright red bleeding with a firm fundus, that is an indication that trauma was done due to the use of a vacuum. So because you have a firm fundus, so you're not bleeding from your placenta site, you're bleeding from the vaginal tear or laceration. And then also observing that neonate for trauma after birth, looking for facial symmetry. One of the big things that can happen is it can cause brachial nerve damage, damage to one side of the face or the other, so you can have facial drooping afterwards. Again, very uncommon. I've seen a lot of vacuums. I've seen a lot of vacuums successfully. I honestly think I've only seen two that were unsuccessful. They wound up going to the OR, and they had a healthy baby. The vacuum didn't do any damage, but it didn't help them to deliver vaginally at that point either. And in both of those cases, the physician did not go beyond the 3 pop-off mark. So that's how we keep babies safe while using that vaginal vacuum option for delivery. Indications for an episiotomy, to make that incision in the perineum, would be if we had a shoulder dystocia. We didn't cover this. We'll cover this in abnormal intrapartum, but just so you know, just kind of quickly, the shoulder can get stuck on the pubic bone, and we may need more room for that on that bottom shoulder to deliver. So we would cut an episiotomy. If you're using a vacuum, you should probably cut an episiotomy because you're probably going to tear. And there's a age-old debate on whether letting them tear is better, or making an incision. The benefit to making an incision with an episiotomy is that you have clean edges. If you have a laceration and they tear on their own, then it's harder to put the pieces of the puzzle back together. So most physicians prefer an episiotomy over tearing naturally, and of course we try and have them tear not at all, but sometimes that's pretty impossible. The other reason for to cut an episiotomy is with a macrosomic baby, so a baby over 4,500 grams. 2 different styles of episiotomies. You can do a median or a midline. The median or midline, it heals better, and there's less blood loss associated with that, but there is a higher risk of tearing that episiotomy extending down into the rectum. So that is not usually the favorable method that I see used. I more so see the mediolateral, which is on the right hand side. It is harder to heal, and it's a little bit more painful afterwards, but there is minimal risk for it to tear to the anus and cause difficulty with the anal sphincter. So we prefer to use the mediolateral approach. And usually if they have a second baby, they tend to tear along that same scar line, and it's pretty easy to repair again. Risks associated with this, infection, of course, because you're making an incision, and then perineal pain. So afterwards they are pretty uncomfortable, and you want to kind of shift their weight back and forth to promote healing. We give them the topicals and ice packs to help with this, and it's usually dissolvable stitches, so those stitches just kind of dissolve on their own, and they don't have to go in and get them removed or anything like that. Our nursing considerations in terms of an episiotomy, we want to avoid an episiotomy if we can. We want to avoid any kind of laceration or tearing if we can. So we want to promote gradual stretching of the perineum during the second stage. So slow and steady wins the race here as well. You want to get the baby out, but you want slow, controlled pushing. When babies are blown out, okay, that's kind of a phrase that we use, oh, she blew that baby out, you're more likely to tear your perineal tissue, as opposed to if you kind of go slow and let the baby's head stretch the perineum with each push, then you're less likely to tear. We do something called perineum massage with oils. At delivery, the physician will kind of massage the perineal area and help coax it to stretch instead of tear. There is also some indications prior to going into labor. Some women will do perineal massage on their own with primrose oil. It helps to really kind of loosen the tissue fibers, so you can kind of almost prep the perineal area for labor and the second stage and delivery to help decrease the risk of tearing. Delay pushing until the urge is felt. So we talked about laboring down. It's important not to make them push before their body is ready to push. And then push with an open glottis. This is in black and bold letters and underlined because for a reason. Okay, so we want to make sure that we are teaching patients not to hold their breath when they push their babies out. That is what AWAN recommends. That's not probably what you would see in a clinical setting. Women naturally hold their breath. We encourage them not to. I actually see physicians who encourage them to hold their breath still. It's against what studies have shown in terms of, preventing tearing and lacerations. Just because if you're holding your breath and you're pushing so forcefully, it's not as controlled as if you are bearing down and pushing with an open glottis, meaning you're not holding your breath. That's all that really means. And then we're going to observe for hematoma and edema after delivery in the perineal area. Okay, so C-section birth. Many different indications for a cesarean birth. Okay, so a shoulder dystocia, if there's a head cephalopelvic disproportion where the head is and the pelvis do not match up appropriately in order for the baby's head to pass through the vagina or the vaginal canal or the pubic bone or through the pelvic bones, the pelvic structure. Maternal hypertension, so if they have preeclampsia that is really out of control and we need to deliver them quickly, so that would fall into maternal disease along with maternal diabetes. Heart disease, if mom had a medical heart condition, that would fall in that category as well. If they have an active genital herpes, they cannot deliver vaginally. If they do not have active lesions, then they can deliver vaginally. So if it is active, they need to go to the OR. Previous uterine surgical procedures would be indication for a C-section birth. They can do a VBAC, but they have to, go to a hospital that they perform VBACs. Currently, Saratoga and Glens Falls do not do VBACs. They'd have to go to Albany or St. Peter's. Persistent indeterminate or abnormal fetal heart rate patterns. Babies can tank for some reason or another, and we have to take them to the OR and get them out quicker than what the labor would allow. And then prolapsed umbilical cord. So if that cord comes out through the vagina prior to the baby's head and it kind of occludes that cord, that's a medical emergency and we're going to the OR for that. Maternal risks associated with cesarean birth, you really just have to think about what are the risks for a mom who's having surgery. Okay, so infection, bleeding, urinary tract trauma or infection. They're getting a Foley if they're going to the OR, so that's the big one there. Thrombophlebitis or thromboembolism, so DVTs. Anybody who goes to the OR is at risk for DVT. Pyrolytic ileus, so you're decreasing their peristalsis in the part of their bowel. You want to slowly introduce food back into their diet after they've had an abdominal surgery, because if you introduce it too quickly, their bowel is very sluggish and they can actually have a piece of that bowel that there is no peristalsis at all, which can cause a bowel obstruction if you continue to feed them. Atelectasis is a collection in their lungs, so they don't want to take big deep breaths because they've had a painful abdominal incision, and they can develop atelectasis, which can then lead to pneumonia. Endomyometritis is an infection of the uterine lining. So again, that's an infection that can happen because we're making an incision into their uterus. And then there's all sorts of complications related to anesthesia. So a lot of risks. It's not just, people are like, oh, I'll just have a section. It's not, it's not a picnic. It's, and it's not, it's the recovery for a cesarean birth. You're not up and moving 2 hours after your delivery and your epidural has worn off. You are, taking it slow. It's a big surgery. It's open. It's a decent size incision site. It's not something to be taken lightly. And I think sometimes we take it a little bit lighter than we should. So the technique of a C-section, I wish some of you would have gotten to see one this semester, but um, they're kind of hit or miss anyways, so you may not have gotten to see one anyways. Especially on 2 to 11, they're not scheduled at that time, so it's only if someone like is in labor and then needs to transition to a C-section. But what kind of preparation do we do as the nurse? We want to make sure all their labs, they'll have the lab work when they are admitted anyways, so CBC, type and cross to the lab. We will make sure that they are seen by anesthesia, they're consented for anesthesia, usually it's a spinal, unless their platelets are below 100 or 100,000. Then they will need to have general. We want to make sure that we're performing a timeout for the anesthesia, the spinal placement, in addition to the surgery. Fetal surveillance, we do a fetal check, a heart rate check on the OR table before they start, just to kind of get that last, like, how's that baby doing before they make an incision? How quickly do they have to go? Really, that's what that adds to up to. We give every mom prophylactic antibiotics prior to going to the OR. So within a half an hour of the incision, we like to have the antibiotics given. It's usually Ansef. We give Ansef 2 grams. We do a skin prep. Sometimes the nurse will complete the skin prep, and sometimes the physician will. I always think that's kind of fun. I actually love doing skin preps. It's like painting a belly. It's really fun. It's usually betadine that we use. Sometimes they use ChloraPrep as well. So not in addition to, but those are 2 options. They need a Foley before they go to the OR, so they can have the Foley in the room prior to going into the or they can have the Foley once their spinal is placed and they're numb in the OR so that they don't feel it. I think it's always good. I would prefer to have my Foley in it when I couldn't feel it, so I always advocate for them to have their Foley in the OR. And then we provide them education about, who's going to be in the room and how's it going to happen, and, basically just everything that they need to know in order to, what to expect through the experience. So I like to cover with you guys who's going to be in the room. It's a lot of people. And it's an interesting feeling to be the center of all of those people. So you have an anesthesiologist who is up by your head. You have a physician who's performing the surgery. You have an assist to that physician, so it's either a physician or a midwife performing the assist. You have a scrub tech that is handing instruments and also has their hands in the field. You have the circulating nurse who is in charge of in charge of the mom. No, she could have been a laboring mom, but if you were the labor nurse and then you had to go to the OR, you're going to the OR with that patient. So you have the circulating nurse who's kind of getting equipment, doing the counts with the scrub tech to make sure that we don't leave instruments behind in the body. You have a respiratory therapist there for respiratory support for baby if needed. You have the nursery nurse, who takes care of the baby once the baby comes out. And sometimes if the anesthesiologist is a nurse anesthetist, you also have an additional anesthesiologist in the room until the baby comes out. So that's a lot of people. Not to mention you have your support person also up by the head of the bed. So it can feel, I always like to, if in a regular class situation, I usually pull people up and kind of put all the people there that need to be there. So you can kind of get a visual about how it would feel to be the person in the middle of that room. I think it helps really put it in perspective. And then add a nursing student in there too. Usually there's a student in there to see the procedure. So all I'm just saying is, we have to be aware that these people in the OR, like, it's a very, it can be pretty scary to be the center of all that. Different types of incisions. So there's a incision that we talk about in terms of what's the incision at the skin level, and then what is the incision look like at the uterine level. So there's low transverse, low vertical, and then classical for each level. So for skin and then for uterine. So I'm going to show you in the next slides pictures of each. So this on the left hand side, these are skin. These are at the skin level. So this one on the left is the low transverse. That's what we 99% of the time see these days. It's like a little smiley face. And then the one on the right is a low vertical incision. I've never seen that in my time, okay, as a nurse. So in 9 years, I have never seen that. They do sometimes do that in an emergency situation, but I've been in a few situations where I thought, oh, they'll probably cut a vertical incision, and they didn't. So the preferred method is this low transverse over here at the skin level. So these are both the skin incision. So then this you can tell is the uterus incision. So again, they can do a low transverse in the uterus 99% of the time. Low vertical is less, and then a classical is even less than that. The other incision style that you need to know about is a T incision. So sometimes they'll cut this low transverse and then they can't get the baby out, and then they do a low vertical on top of this low transverse, so it winds up being like an upside down T. So an incision right here in addition to this low transverse. If you had that type of incision, you cannot have a VBAC. I'm going to repeat that. If you have a T incision where they've cut a low transverse and then a low vertical on top of that, you cannot have a VBAC. Okay. Nursing considerations, in addition to everything that we've already talked about, is emotional support. So this can be really difficult for patients, especially if they were not planning on a C-section delivery, and they really had their heart set on a vaginal birth. Again, at the end of the day, healthy mom, healthy baby. It's hard to put it in perspective, but we really have to help these moms understand that, you know, they did the best they could. It's not their fault. Things happen in labor that you can't control. So it's really hard sometimes, especially initially, and they don't really want to hear it from you most of the time, but trying to let them cry if they need to cry, talk if they need to talk, let them feel whatever they need to feel so that they don't, you know, kind of stuff it away. And then, you know, I mean, there are moms who have PTSD from the fact that they can't have a vaginal delivery. It can be pretty severe and also a precursor to postpartum depression. So it's really important to be listening ears. My big thing about C-sections, so this is just Corey's world and my idea about C-sections. So we have, in this country, we have a very high C-section rate, okay? And other countries do not. And we get kind of a bad rap for that, you know, oh, we have such a high C-section rate, our vaginal births are low, and they're always trying to get us to decrease those cesarean rates. And my thought is, okay, so we are, you know, saving, essentially, years ago, women, if they didn't deliver vaginally, they died. Okay, they would die in childbirth because they couldn't have the baby. The baby would die, or they would get an infection and die. There were poor outcomes for mom for birth. It was very risky to have a baby. So as modern medicine developed, we started doing C-sections to remove those babies that once would have died, that their mothers would have died, and we saved, no offense, all the bad pelvises. Okay, so those bad pelvises that couldn't pass a fetus, we were saving them now. Okay, so not only did you save the woman with the bad pelvis to then have another baby, you also saved that fetus who was probably, you know, a female, potentially 50% chance, right? A female, and then that genetic makeup, that genetically bad pelvis is passed on to that daughter. So now we have, years and years later, we have a bunch of bad pelvises out there. And I don't mean that in a negative way. I just mean it in, of course, we want to save those people. People are not pelvises, right? We're not, going through with natural selection here. We're saving those people. So naturally, our C-section rate, I would think, would go up because now we have a lot of people a lot of women with pelvises that, you know, back in the day would have died, but now we save them all and we continue to. So, process of evolution, we aren't eliminating the people who don't have good pelvises. I'm sorry, that was a huge tangent, but it's a tangent that I go on every semester because I feel like people get really upset about the level of C-sections in our country when the truth is it's a result of saving people who needed to be saved. And that's just my take on it. So, and I think that's important to bring up when women are very upset about the fact that they had to have a C-section birth. I wouldn't necessarily say, oh, we saved you. You would have died otherwise. I would not say that. But I would, it is okay, not initially, but to kind of talk about how it's a necessary thing to save people's lives from, in under normal circumstances, people would not have survived some of these situations. So we're responsible also for teaching. So teaching them from start to finish what to expect from their section, what to expect in the 24 hours after delivery, promoting safety, and then provide post-operative care, care of the infant and care of the mom. That is one really awesome thing about working in OB. You can be a labor nurse in the morning. You can be a circulating nurse midday in the OR. You can be a PACU nurse after the OR in the afternoon, and then you're a postpartum nurse. So you've really taken on a lot of different roles in one position. So that's one of the things that I really love about this job is you've got a lot of things to learn. You've got a lot of different roles to play, and it's different every single day with every single delivery.